Hello, everyone. Wishing you best of health during these very difficult times. It's an honor to present this very interesting topic. We're often faced with patients with post-op or acute injury pain. Given the current opioid crisis, it's important for us to consider other multimodal approaches, such as NSAIDs. My disclosure. So why use NSAIDs? Well, as we know, when combined with opioids, it has a synergistic effect that's superior to opioid alone. Additionally, many studies have shown that NSAIDs reduces the use of opioids to reduce post-op rescue pain. This in turn reduces possible complications of opioid by about 20 to 30%, such as overdose and death. Interesting enough, the US makes up about 4.6% of the world's population, yet consumes 80% of all opioids. Other countries mainly prescribe NSAIDs post-operatively, and studies have shown, including those by Fader et al., noted that there were no statistical differences when compared with healing time of cases between the US and other countries. NSAID has also been shown to reduce length of stay post-operatively and are effective in reducing and preventing pathologic heterotrophic ossification. Also, NSAIDs are known to stimulate collagen synthesis, so it's feasible for us to infer that it can improve soft tissue healing and improve stability of fractures. With all of these benefits, why not use NSAIDs? Well, in the early 2000s, there were several in vitro and in vivo animal studies linking NSAIDs to delayed union. As a review, bone healing occurs in 4 main phases: the early hematoma or inflammatory, the soft callus, the hard callus, and then the remodeling. And it is in this early stage, immediately after a fracture, cyclooxygenase or COX-2 production of prostaglandin, which plays a very important role in fracture healing, is most elevated. So how does the mechanism of NSAIDs inhibit bone healing? Well, COX-2 is an enzyme that converts arachidonic acid into prostaglandin E2, which stimulates mesenchymal or mesenchymal chondrocytes and osteocyte cells to differentiate to mature cells. So NSAIDs actually block this cascade, which can result in delayed or non-union. This delayed healing has been shown most in animal studies. So what are the results of these animal studies? Well, in multiple studies, including these earlier trials, both in vitro and in vivo trials, COX inhibitors show a deleterious effect on bone healing. These studies have been supported by experiments using what's called the COX-2 knockout mice, where bone healing is significantly delayed as these animals are devoid of COX-2. So based on these findings, animal trials have recommended avoid NSAID use. But how convincing are these animal trials? Well, the results are clear that NSAIDs are detrimental to bone healing. However, several follow-up studies have shown that many of the animal studies that resulted in impaired healing were of lower quality. Most of these studies were mainly on rodents. When studies were actually conducted on animals which are more similar to humans, they reported minimal to no impairment of bone healing. It's also important to remember that good animal studies don't always translate well into human experiments. For example, thalidomide was not harmful to animals, but corticosteroid was harmful to animals. And then a recent leukemia drug called TGN-1412 was tested safe on monkeys, but yet caused multi-organ failure in humans. And I also like to think that chocolate is extremely healthy for humans, but unfortunately toxic to dogs. Also, many of these animal studies had significant variation in NSAID usage, including the dosing, the duration, the timing, and types. Some studies dosing of ketorolac used greater than 6 times the human dose, with duration of exposure exceeding 12 weeks versus our usual clinical dose of about 1 week. Additionally, these animal trials did not report whether selective versus non-selective NSAIDs were given and whether it was an early versus late stage of healing, which makes it very difficult to have a high qualitative systematic review. Despite the lack of these consistencies, the recommendations were to avoid NSAIDs. So how does this compare with the clinical or human trials, and what were those results? Well, several studies showed a high non-union rate with use of NSAIDs in long bone and spine, especially at higher dose, as noted by Lumewig et al., where in this particular study, 45 out of 273 patients developed delayed spinal union when higher doses of diclofenac was consumed. And then a recent study by Fedko et al. Described 70% increase of incidence of stress fracture and delayed healing in about 7,000 active military servicemen who were taking NSAIDs compared to those approximately 28,000 who did not receive any NSAIDs. They also noted that timing of exposure played an important role. Those who had taken NSAIDs prior to sustaining these stress fractures had an increased incidence of delayed healing. Again, this supports the timing of NSAIDs is important during the early stages of healing. So these clinical studies also recommended avoid NSAIDs. However, many other studies, including those by McDonald and by Hassan and Ali, showed that NSAIDs, if consumed less than 14 days, there are minimal negative effects on bone healing and soft tissue healing. And then, as expected, lower or normal dose of NSAIDs also have less negative side effects compared to higher dosing regimen on bone healing. So these studies mainly focused and reported on short-term use of non-selective NSAIDs such as ketorolac, ibuprofen, and indocin. And it's been demonstrated that non-selective NSAID causes only temporary effect on bone healing and is usually quickly reversible once stopped. Based on these newer studies, the recommendation from them is that maybe short-term NSAID is okay. So as discussed earlier, COX-2 is a key component of bone healing pathway, and it would be expected that when non-selective NSAID is compared with selective NSAID, such as celecoxib, we would find different results. So what were some of these outcomes of these studies? Well, there were two studies by Ghosh and George who completed a systematic review and a national database search, respectively. Ghosh in 2019's review of studies included 44 in vitro, in vivo, and clinical trials. George's database was of approximately 340,000 patients. Interesting, both studies found that when non-selective NSAIDs were compared to selective NSAIDs, non-selective NSAIDs had minimal effect on impeding bone healing. So these studies actually supported the use of short-term non-selective NSAIDs. So, but how convincing are these clinical or human trials? Well, unfortunately, there continues to be limited, large perspective quality RCTs, and there are still conflicting results of meta-analysis. For example, some reviews which were considered high-quality studies included pediatric patients, and we know they're known to have less delayed unions in general, and several studies were actually underpowered. Other studies included different types of bone, including long bone versus spine. Additionally, the interpretation of data can be difficult. For example, the definition of delayed versus non-union was inconsistent. Several authors used reoperation criteria, while others used clinical versus radiographic findings. We know some studies have shown that radiographic interpretation has up to about 20 to 25 interphysician variation for fracture healing. And other confounding factors included types, dose, time, and length of exposure to NSAIDs. Additionally, many of these reviews also relied on questionnaires, which can be biased by the patient's recollection or concern with answering how much opioid they actually consume, while other studies relied on numbers of refills, which may not be a true reflection of how much was actually consumed. And most importantly, there's a lot of variability in patient demographics, such as patient-dependent factors like comorbidities, age group, and then independent factors like fracture type and whether whether patients were smoking or not, and that was not very well delineated. So hence a different conclusion, such as some studies said avoid all NSAID, others said just avoid selective COX-2 inhibitors, while others recommended short-term use of non-selective NSAID. So why is there so much discrepancy between basic science and clinical studies? Well, the theory of COX-2 mechanism to inhibit bone healing or bone fusion is clear. However, the effects of NSAIDs on different bone pathology is not as clear. For example, it impedes fracture healing through a decrease of osteoblast differentiation, but has a different effect in decreasing bone loss when used inflammatory conditions such as arthritis. The other main discrepancy is that experimental settings didn't always match the usual clinical setting scenario. In terms of timing, we know that prostaglandin E2 is elevated in the first 2 weeks of callus formation and decreases drastically by 21 days. Well, unfortunately, most of the animal studies use NSAIDs in the early stages. Animal trial NSAIDs length of exposure also did not match clinical setting. And some animal studies use selective NSAIDs for up to 12 weeks. This is really important as non-selective NSAID is reversible when cessation of the drug occurs. Hence, prolonged use would be proportionate to delayed healing. So taking all of this into account, what's a verdict based on the systematic reviews and meta-analysis? Well, unfortunately, even with the most updated review that occurred in 2019-2020 on soft tissue, bone and tendon, and bone healing by Constantinescu, Dushman, and also Ali, respectively, the finding states that though there were minimal adverse effects of non-selective compared to selective NSAIDs, many of these studies were still lower quality, some were underpowered, some were not randomized controlled trials at all. And given the limitation of a large qualitative randomized controlled trial, unfortunately, the findings were inconclusive and do not provide sufficient evidence for or against the use of NSAIDs post-operatively or after acute injury. So in summary, what do we know? We know that animal data is clear, that NSAID impedes bone healing. Unfortunately, clinical or human data is less clear. NSAIDs on bone healing may be dependent on dose, timing, type, and length of exposure. And at this time, it's inconclusive, and there's not sufficient evidence for or against the use of NSAIDs post-operatively or acute injury. However, if NSAID is used, the recommendations are consider using it on a case-by-case basis. For example, this is a straightforward case, but should be avoided in these other types of cases. And then restricting standard dosage to no more than 7 to 14 days. Again, limit the use at the time of greatest negative impact, as when prostaglandin is at the highest level the first 2 weeks. And then obviously discontinue NSAIDs, there's evidence of delay, and then absolutely important to avoid it in high-risk patients. Thank you very much. Again, please stay safe and healthy. Questions?